Hello and welcome to Noon Conference, hosted by Medality. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. You can access the recording of today's conference and previous Noon conferences by creating a free account. Today, we are honored to welcome Dr. Sally Ayesa for a lecture entitled Introduction to PET Imaging of the Brain. Dr. Ayesa is a radiologist, nuclear medicine specialist, and academic based in Sydney, Australia. She serves as the specialty lead for medical imaging at the University of Sydney and has special interests in oncology imaging and thoracic radiology. At the end of the lecture, please join Dr. Ayesa in a Q&A session where she will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Ayesa, please take it from here.
Good morning, everybody, and I'll just unmute my mic and start my video. And thank you so much to Medality for having me along today. It's a real pleasure. This is the first time I've had the privilege of presenting at Noon Conference. It is 9 a.m. in Australia, and so I apologize for the interesting time that you're all joining us with today. But thank you for coming along at the end of your workday. I really appreciate you being online. As the introduction mentioned, I'm a nuclear medicine specialist and radiologist from Sydney, Australia. And today we're going to be talking about a bit of an introduction to PET imaging of the brain. And I report a lot of PET. I really enjoy it. So hopefully you enjoy this introductory talk. So I do have a couple of disclosures, mostly just from teaching at different outlets, including Siemens, Radiopedia, and Medality. So as we jump in, I'm very conscious that a lot of you will be joining from different places around the world, including North America, where Medality is based, but also all around the globe. So just a little bit about where I am joining you from today. I'm from Sydney, which is on the east coast of Australia, and here is our map of Sydney. And if you've heard of the Sydney Opera House, that is about here. And I work up here at Royal North Shore Hospital and down here at the University of Sydney, and then living out in a place called the Hills District in northwestern Sydney, which is a really beautiful part of the world. This is near where I live. These are Sydney blue gums, so it's a big theme here today. They're actually a threatened species because they grow so tall and straight. People are using them for telegraph poles, but this is a really beautiful part of the world. And here's one of the most historic buildings at the University of Sydney. This is our quad with the Grand Hall. Unfortunately, I don't have an office in this beautiful part of the university, but it is the most iconic shot. And here is the original Royal North Shore Hospital, which no longer looks like that. It looks like, although that building does still stand, I only took that photo about 3 weeks ago, but here is where I work. I work in the yellow part of this building, not quite in the basement, on level 2 above radiation oncology at the back of Royal North Shore Hospital in Sydney's north. I'm very lucky. I'm part of the Australian National Total Body PET facility. So we have a fantastic camera, which allows us to do really high-end PET imaging. And we do that in conjunction with the National Imaging Facility and the University of Sydney with Sydney Local Health. So that's a little bit about me. And today we're going to be talking about different ways that we can image the brain using PET scans. So starting with some neurodegenerative conditions, and traditionally this has kind of been where a lot of the where the meat of what we do has come from, but also brain tumours, which is going to be our second part. And initially when I wrote this lecture, and thank you very much to Medical College Wisconsin, who I helped me develop, which I developed this lecture initially from, and then we've revamped it and reworked it for our noon case conference today. They were really interested in, how we can use different traces to image the brain. And you may be familiar with F18 FDG, or our glucose PET, which is what we use for all of our oncology, well, not all of our, sorry, for a large proportion of our oncology imaging. And so that's been the workhorse. But we are so blessed to be living in a time at the moment where we have so many different traces to be able to demonstrate different pathological and physiological processes through the brain. And just because we're kind of head and neck adjacent, we're going to finish off with F18 choline and looking at parathyroid adenomas, which can be a diagnostic challenge in the head and neck. Not quite brain, but something really interesting, and I had to throw it in there at the end. So for those of you who may be unfamiliar with PET or just learning, PET is positron emission tomography. And I'll just restart that animation actually. So if we restart it, so we have our radionuclide, And as the positron emitter decays, it throws out a positron, which is an antimatter particle. It's an anti-electron. When antimatter meets matter, it annihilates each other. So when a positron meets an electron, it annihilates each other and then throws off two gamma photons at 180 degrees to each other, called coincidence photons. They always have 511 keV energy. And then when we put this tracer into the patient, so the radiopharmaceutical being F18 or fluoride 18 or gallium 68 into a patient, it emits a positron. And then when that annihilation reaction happens and those photons are sent out at 180 degrees to each other, the camera detects both of those and they know that that reaction happens somewhere along that line. When this happens millions and millions of times and we get millions and millions of what we call coincidence photons, we're able to build up a three-dimensional image, which gives us the distribution of the radio tracer within the patient. Now, I've thrown out a few different words, and for some of you new to PET might be a little bit confused with all the terminology. I know I was when I started. So we have a radioisotope, which is decaying to throw out a particle or a gamma ray, and then it's tagged onto a pharmaceutical. And together that's called the radiopharmaceutical. Your pharmaceutical might be FDG or fluorodeoxyglucose or dotatate or PSMA for prostate cancer. So there's some ones you might come across. So it's something that can interact with the body like a drug with a tag, radioactive tag on it, and that is our radiopharmaceutical. And that is the basis of nuclear medicine and PET imaging. So let's move on. So we're going to be starting with dementia imaging, and the largest proportion of cases for today are going to come into this section. And because dementia imaging of the brain with PET is just such a big part of what we do and where we can help. Is PET scans for the brains, are we usually a first line investigation? Not really. We can't compete with something like CT brains or MRI for certain pathologies, but PET is an excellent problem solver, particularly for difficult cases and also for neurodegenerative conditions where you need the best diagnostic certainty we can get. Looking at the patterns of uptake can be really useful. So when we assess dementia on F18 FDG, we're trying to map glucose uptake in the brain. So the brain itself takes up a lot of sugar. On a regular PET scan, even if you do it for lung cancer, the brain is always going to be hot. So you are going to be looking to see if the brain is taking up the glucose and using the sugar normally or abnormally. So basically, and the principle of this is that glucose uptake reflects neuronal and synaptic function. So then if there's hypometabolism, and when I say hypometabolism, it means there's less metabolism and less sugar being taken up than we expect, that can be a sign of neurodegeneration. And certain types of dementias will demonstrate characteristic patterns of reduced uptake of the tracer. But why does it matter? And it matters because the way that we treat neurodegenerative conditions, including Alzheimer's, is changing. We now have medication options, and if we can detect neurodegeneration and Alzheimer's disease early, potentially by administering these medications, we would be able to modify the disease course. And then also, if somebody may have Alzheimer's or may not, you also have to be mindful that we want to be certain that they do have Alzheimer's, because if you start them on a medication which potentially may have side effects and they don't actually have the condition you're trying to treat, there's that risk benefit in there as well that we need to think about. So just as we go in, just a note about total body PET and the challenge that we have with brain imaging is that with total body PET, you're imaging the whole body at once. When traditional PET scanners and digital PET scanners have a scanning bed, which is about 30 centimeters, which is perfect, top of the head down to, the neck, great, you're only imaging the brain. But we've ended up with a bit of a challenge that we're capturing the whole person. And this is the head holder up here, but we can't, if we image this whole body, then what do we do? What is the ethics of having to interpret that whole body, the pictures of that person's entire body? So I've ended up sliding our patients down a little bit. We're still getting part of the thorax though, and we can end up with conditions like this. So this is a patient who has had a dementia brain study, but now we've got a lung nodule. And what do we do? This person could be 90, 95, 100 years old. And so what's the ethics of finding things that we might be exposed to that we may not have found otherwise if we were only doing dedicated brain imaging? So I'll just leave that one with you just there. Okay, so as we jump in, I'm going to show you two main different ways of how we display the images when we're looking at dementia brains. So the first thing is our 3D reconstruction, and PET data is reconstructed exactly like MRI and CT as a scrollable stack. You can adjust the levels, but we do a lot more with fusion. So PET-CT is always acquired with a PET, which is our functional data, and a CT, which is our anatomical data. And the CT is useful not only for anatomical correlation, but also attenuation correction, which means getting the levels of the tracer correct and reducing artifacts. So this is what we do, but we can see that the brain is very, very hot. So I'm constantly adjusting these levels to see more detail. So you can see that I've just moved that up and down, and now we can see more detail in the brain. And I can see that there are some red areas and some are less areas. So there are less red. But what does that color scale really mean? So we're going through and I'm adjusting it down. And similar to when you're looking at lung windows, you're constantly adjusting your windows. You're trying to look in vessels, exactly the same with PET. But what does the color scale mean? So on this particular, in this particular image, the red is where there is most uptake or greatest metabolism, and I can adjust it to make it look like anything. But the red means that there is the greatest metabolism, which is often in this is going to be normal in dementia imaging. If it's blue, so it goes down in a rainbow scale: red, orange, yellow, green, blue. So once we're blue, that's least uptake. So what I'm looking at in these regions is areas of reduction, like here, where it should be red, but instead we're getting down towards yellow, green, blue. So reduced uptake. And just keep in mind that this is different to another type of way that we display the images in PET dementia brains, which is like this. And this is a brain mapping or a statistical analysis where we push the data against a normal population. So we're looking for, is there reduction in the uptake or the metabolism in certain areas of the brain compared to what we would expect for a normal person? In this, the color scale is flipped. Red is bad, blue to green is mild reduction, yellow and orange is moderate reduction, and red is severe reduction. So it's flipped compared to those. The grayscale is essentially just normal. You can see here that the cerebellum is normal, but through here, all these red areas, they're the most abnormal. So just keep that difference in mind as we go through and look at the cases. And we're going to start with Alzheimer's, which is got a very characteristic pattern. But that said, it's very, very common. And we all know in radiology that not every single patient is going to read the textbook. So not every Alzheimer's patient is going to look like this, but this is a nice textbook example of the characteristic findings that we are looking for with Alzheimer's. We're looking for reduced uptake in the precuneus, the inferior parietal lobule, middle temporal gyrus, and posterior cingulate cortex. But I'm not going to throw it at that. I think that would just be mean. Let's go back and review the anatomy, because I've found that reading dementia brains has really forced me to improve my anatomy to understand these different areas of the brain. So firstly, looking at the medial cortex, we'll look for the cingulate gyrus, and then the posterior cingulate gyrus is the back here. And this is a really important structure in Alzheimer's, because the posterior cingulate gyrus should be the hottest or most red part of the brain on those standard reconstruction images. It should be chewing up the most glucose. So if the posterior cingulate gyrus is not the hottest part of the brain, then we need to start thinking about Alzheimer's disease. And then we also want to think about the precuneus as well, which is here marked in blue. And when we put it overlaid onto our statistical map, you can see that there is yellow, red, and blue and green through the posterior cingulate gyrus and the precuneus, which corresponds to those anatomical areas. I will just jump back quickly to the posterior cingulate gyrus as well, because when we are diagnosing Alzheimer's, you really just don't want to see just decrease in the posterior cingulate gyrus, because this can indicate an alternative diagnosis or amnesic mild cortical cognitive impairment, which is a separate diagnosis. But 1/4 of these patients will go on to Alzheimer's disease, so it may very well be a precursor situation. But if you're starting to see precuneus, like we see here, and these other regions seen at the lateral cortex, then you can be more confident in your diagnosis of Alzheimer's. So here, inferior parietal lobule here marked in yellow, and then the middle temporal gyrus marked in purple, that when we look at the map with reduction in these areas, it almost gives you this kind of draping look, this kind of draped pattern down the lateral aspect of the brain. So how do I go about reading these? So here's a little video that I captured of me making my adjustments. So we always get kind of grayscale to start with, and then you can apply your color maps. I love to look at the grayscale first because I think it's more sensitive in the brain or sensitive for looking at PET scans. But keeping in mind with the brain, the color scale is really useful because you're looking for degradations of reduction. I like to use PET rainbow My colleagues like to use this one. And so I'm very strange in my department because I like to use rainbow, whereas warm metal is favored by my colleagues. They love the purple, orange, white one. And white is the area of greatest metabolism or most normal. Where things start to go pinky purple, that's where you're worried that there's a reduction. So coming through here, if we look in the region of the posterior cingulate gyrus, when we go back to my favorite color scale here, which is PET rainbow, you can see that it's not red. And I'm going to go through, there we go, we're making my adjustments. We're constantly adjusting. So right where the arrow is here, now these are the lateral parietal lobes and we'll see precuneus in a moment. But really that posterior cingulate gyrus, which is just through here, it's got a little bit of uptake, but here it's not the hottest part of the brain. And so that's where going back and looking at my statistical map as well was really useful, because what I was seeing visually, I could confirm it on the statistical map, almost like having a second reader. So here again, this is the full vision of this case. And then, so this was considered consistent with Alzheimer's disease. And then here's a comparison case as well, which demonstrates all those findings that we saw before, actually more marked reduction in precuneus and posterior cingulate, again, with that draping pattern through the lateral parietal lobe through to the middle temporal gyrus coming through here, that draping look. But you can notice it's asymmetrical, and it can be. But there's also, if you'll notice, there's other areas of reduction. So frontal lobes as well, different parts of the temporal lobe can have reduction too in severe Alzheimer's. So that won't dissuade me from the diagnosis because we've got those quite typical features. So I've just got a question in the chat, and I'll try my best to keep up with them as we go. Any suggestions to distinguish volume loss versus true reduction? Sometimes it's hard to know which came first, reduced metabolism or loss of volume leading to this. That's a really tough one. And I think kind of that's more coming down to the pathology. So when I'm looking at PET scans, I don't really the anatomical imaging isn't at the forefront of my mind. I'm really looking at the functional data. So I'm sorry I don't have the answer to that. But I dare say that they probably go hand in hand. The reduced metabolism is reflective of that neurodegeneration, and therefore the cortical loss is mimicking that pathology. But I will tell you that sometimes we do see metabolism loss in fairly normal looking brains. If I were to hazard a guess, and please don't quote me on it, maybe we are seeing that reduction earlier. And when we go, so Mitesh, when we actually go to look at amyloid PET in a few slides time, you'll get a sense of, well, that we're also seeing more precursors as well. Sometimes the brains, when we're looking at amyloid PET, so looking for amyloid plaque deposition, you have preserved volume. Okay, so Alex has asked, are there confounds for PET with CSF pulsation variations? Would motion artifacts reduce apparent uptake adjacent to the ventricles? That's a great question. It hasn't something I've come across. I think with pulsation as well, the movement is kind of going to be quite small. And because with MRI, yes, it's much more sensitive and the voxel size is smaller. But PET and nuclear medicine inherently has a lower spatial resolution. What we do see sometimes with with this statistical map that we have up on the screen at the moment is some misregistration. So you can, if the brain's very atrophic, it might fall off it a little bit. And I kind of noticed through here, sometimes you've got a stripe, even though the cingulate gyrus is normal, and that's just from the atrophy, just pulling it off a bit. So every time I'm reading these, and probably this is a little bit more advanced, is I'm always looking at the three-dimensional data first. I'll make a decision, and then I'll go and check myself on the neurostat. And that helps me to determine artifacts and also, quality assure my work. So yeah, hopefully that helps. Okay, great. Just double checking, we can see my mouse as well. Hopefully I'm sharing the right screen. I always just dive in and hope for the best, but that should all be fine. Okay, great. Let's keep going. Okay, so we're going to move on to frontotemporal dementia. We'll go through these next ones a little bit quickly so we can get to the back of the presentation with some new traces. Frontotemporal dementia is massive. There's so many different patterns of how it can present and the differences in metabolism. And that's just because it's multiple neurological syndromes which overlap. There's multiple subclassification, and in over 50%, it's associated with abnormal tau deposition as the protein. So here is kind of what we would typically kind of think, frontotemporal. This patient, this on our statistical map, noting that the red areas are the most severely affected. We can see that in this temporal lobe here, there is reduction, but it's also present on the contralateral side as well. particularly, so right and left, and then also reduction medially within the frontal lobes as well. We're seeing preservation of uptake in the posterior cingulate gyrus, and precuneus looks pretty okay as well. A little bit of this kind of blue and green kind of dotted through, that's going to be mostly statistical noise. But that just comes with a lot of reading these. And I wish that I could say that every single time I open a case and go, yeah, that's that's frontotemporal, that's Alzheimer's. Realistically, I have to look really carefully, and I've picked you great cases today, but it's not uncommon for me to go and get a second opinion as well if these do look a little bit confusing, because that's how we roll in our department. We're quite collaborative. But I have picked a couple of variants which have really nice imaging findings. So primary progressive aphasia has 3 subtypes, and we're going to have a quick look at semantic dementia and logopenic progressive aphasia because I found 2 really nice cases in our collection. So semantic dementia, it's a type of frontotemporal dementia which is characterized by marked unilateral anterior lobe atrophy, and it's typically affecting the left side of the brain. So these patients will present with they'll have fluent speech, but they'll have loss of word and object knowledge, and they might have anomia or surface dyslexia and word and object associated agnosia. Lots of big words there, lots of tongue twisters there, but they do have preserved episodic memory. And this is a really classic case here. So we've got the anteromedial temporal lobes and more pronounced on the left, as we can see here. And here's our 3D. I collected us a couple of slices. You can really see that that temporal lobe has asymmetric reduction in uptake. We're seeing these red areas through here, and it's much more gracile and more yellow coming through. And you can really see that visually reflecting that dementia. Even here, not quite normal. Logopenic progressive aphasia is similar, but not quite the same. Left lateral temporoparietal region, and this is really striking. The semantic, yes, it was kind of a bit patchy and it was reduced, but here it's really striking that this part of the brain is most affected. It really kind of jumps out and hits you. And then when we look at our 3-dimensional fused imaging as well, we can see that there's also further reduction through the parietal lobe through here. It's not as red as we would like it to be, and significant marked reduction in the temporal lobe there. I've thrown in some cases of dementia with Lewy bodies because I think the patterns of this are really interesting. So Lewy body dementia is secondary to accumulation of Lewy bodies in the brain with intracellular inclusions and aggregates of misfolded synuclein. And this is that frontal dementia that there's little in the way of memory deficits, which early in the disease, but you can get these kind of fluctuating cognitive impairments and visual hallucinations. I remembered it from medical school as it was called the pixies at the bottom of the garden. So people would see kind of pixies and hallucinate visually. And it can have a lot of overlap with dementia, with Alzheimer's disease. And that's probably the most common indication I see on my request forms is query Alzheimer's, query Lewy body dementia. So if we can distinguish between those, or even say that there isn't a clear pattern to determine either way, that can be really useful for our referrers. So with dementia with Lewy bodies, you get reduced uptake in the occipital lobes and frontal and temporal lobes, as we're seeing here. Lots of kind of stipulated blue, green, and yellow, and a little bit of red coming through those regions. And it does have a mimic of Alzheimer's dementia, but the big difference is the preservation of the posterior cingulate gyrus, which gives rise to the most characteristic and eponymous imaging feature of dementia with Lewy bodies. So just coming through here, looking at our statistical map, you can see here at the back. It's certainly got a predilection for the occipital lobes here. See that it's the greatest reduction, but the posterior cingulate gyrus in here is preserved, which was confirmed on visual inspection, as we'll see on the next slide. And this is what it looks like in the fusion. And you can see that there's the posterior cingulate gyrus is the hottest part of the brain, as we see here, but there's relative reduction in the occipital lobes. Did I put those in? I did not. So the occipital lobes just through there. But the cingulate island sign wasn't as nice as I would have liked on that one. So I've got you the best case I could find of the cingulate island sign, which is the most common kind of textbook appearance of dementia with Lewy bodies. So here, an island of preserved uptake corresponding to the posterior cingulate gyrus with corresponding reduction in uptake in the occipital cortices, which is driving that presentation with those visual hallucinations and cognitive disruption. Finishing up with a relatively new entity, and late or limbic predominant age-related TDP43 encephalopathy, or late, it's been a bit of a new kid on the block in terms of dementia. It's really come into more diagnostic practice within the last 5 years, and it is often seen in the population of patients who are presenting for Alzheimer's related presentations with memory impairments, but often patients who are found to have late are older. The presentation is memory predominant and there's a slower rate of decline. Whereas Alzheimer's, it can be steeper, so late is more prolonged. And they've also got lower ApoE4 as well, and also some genetic changes in comparison. So what does late look like and why is it not Alzheimer's? So late has reduced uptake in the medial temporal lobe and hippocampus. I think this one's a video, that's right. So we're looking at the posterior cingulate gyrus. That looks okay, nice and hot, really red, hottest part of the brain. But as we start to look down at the medial temporal lobes here, and I'll just move on to the next slide, you can see that they are green. Here's the side by side, so I'll annotate the right. And you can see that that medial aspect of the temporal lobe is very green. There's reduction medially compared to even laterally, and certainly compared to other parts of the brain. Like, look how nicely these occipital cortices have preserved metabolism. And this exactly matches on what we see with our biostatistical analysis. Particularly on the left-hand side here, you can see significant reduction with that red area and mild reduction there on the right. Okay, so this is just a nice bit of a summary paper. I wish I could go through and spend hours teaching you all dementia today, but it's just not enough time. But we will pop in the chat a link to this paper. There's a QR code coming up, but we'll be able to give you the PDF. This is a really nice one from the Journal of Nuclear Medicine that just gives the different patterns of uptake associated with the different dementias. And so just we'll pause there and I'll just have a quick look at the questions. What software do we use for the 3D maps? We use MimNeuro. So we use a package called MIM7, and that has a neuro analysis. We've formerly used Neurostat, but at the moment we're using MimNeuro. And what is the role of PET-CT in diagnosing MS? Great question. We don't have a role. MS is really kind of the realm of MRI. PET-CT doesn't really, we don't kind of factor in there. Occasionally we'll do some brain tumor imaging, and I know sometimes tumor factor MS is in the differential, but because there's inflammation as well, we don't really help. So MR is certainly the gold standard. Great question though. Okay. So moving on to other regions of neurodegenerative imaging, including amyloid PET, and thank you to Associate Professor Jeff Chambray and Dr. Ash Raghavan, who's my resident, for helping with some of the information and cases on these slides. So amyloid PET, really exciting. I like, they're really pretty studies, as you'll see in a moment. And there are several different agents, including F18, florbetaben, florbetapir, and flutamidamol. We use florbetaben at Royal North Shore in Sydney. And what we're looking for is imaging of amyloid plaque deposition, which is that's that hallmark of Alzheimer's disease. We're looking for abnormal amyloid plaque deposition within the cerebral cortices. And if that's there at a certain degree, then we can diagnose Alzheimer's disease. Essentially, a normal amyloid PET is going to exclude Alzheimer's, which can be so useful in some of these patients who are presenting with cognitive issues and memory impairment. So this is a normal study. I like to start normal because then I can show you what we should be looking for. And what you can see, it's really almost like a beautiful outline of the white matter. And you can see the ventricles in the middle, ventricles. And what we're looking for is a few hallmarks. So here we're looking for an arboreal pattern. So if I draw the outline, it should be really spiky looking. Because we shouldn't see anything in the cortex. If we see cortex, then the brain's going to look more cloud-like, lobulated. But we should be seeing this nice and spiky, and this is called an arboreal pattern, or like a tree pattern. So here's another animation to kind of help you remember. The other thing we want to see is cortical separation. We want to see a line between the cortices, particularly at the top of the brain, because there should be grey matter in there. So the white matter should be separated. So we want to see cortical separation. The other thing we use, and this is also using MimNeuro, is a package for centiloid analysis. And a centiloid is, we'll come up to the next slide, is a standardized scale looking for the degree of amyloid plaque deposition or tracer uptake in certain areas of the brain. 0 is what we would expect in normal young healthy patients, and then 100 or above, getting up to 100 and above, is where we are confident that we are looking at a typical case of Alzheimer's. So we essentially, the package will do this analysis, and you can see these areas where it's looking at certain areas in the brain, including the posterior cingulate gyrus and the precuneus, those areas where we would expect abnormality in Alzheimer's, as we know from our anatomy that we saw in the previous section. And it can be useful in aiding with our diagnostic certainty, really useful, and also tracking amyloid plaque progression. And sometimes you'll have equivocal cases, they might be borderline, we're not quite sure, and you'll rescan them in 5 years and that will increase. So that progression is really useful. We tend to use thresholds of significance of 10 to 20. So if you're getting above 10 to 20, but in these cases as well, a good proportion of those, it may be very well precursor and they may increase over time. So we may be seeing like a pre-Alzheimer's. But often, in my experience, the vast majority are going to be pretty clear-cut one way or the other. So 50, as I said, 50 is our cutoff for being consistent with Alzheimer's disease as we describe it. And then the computer spits out this table and we look at this centiloid value here and it's almost 0. So this is negative, a negative study. So that's a negative study, and this is a positive study. And hopefully you can kind of see that we've lost that arboreal pattern. It does not look spiky. So I'll pop in, but it's hard to know first off the bat, so I'll pop the normal next to it. So here is our normal comparison, and you can see that we've lost that spikiness, and instead we've got a smooth cortex. So smoothing because there's abnormal tracer uptake in the grey matter. And also we've lost that normal cortical separation. So here's our normal comparison, and here the cortices are almost touching. So that is, again, an abnormal study. So what does the centiloid look like in this patient? Different. So here, our centiloid value is over 100, 134.79, which is consistent with Alzheimer's disease and really useful for a patient like this. And we had that question earlier about kind of our diagnostic certainty and things like that. And it's not uncommon to see only mild cerebral atrophy and not typical CT structural features of Alzheimer's in these patients, or even significant neurodegeneration or atrophy. So amyloids can be really useful even in younger patients for that diagnostic certainty. Great. Okay, feel free to keep asking questions in the chat as well, but we'll move on to Parkinson's disease. And nuclear medicine has been doing DAT scans for a long time. We've had agents in general nuclear medicine, but I always found they were so hard to read. The spatial resolution wasn't great. The signal to noise wasn't great. But now we have a PET tracer, which is FPCT, another fluorine-18-based tracer. And it's great because it binds with really good affinity to the dopamine transporter, and we enable in vivo assessment of the nigrostriatal pathway, which is so important in Parkinson's disease. And we're looking for that structural target. Sorry, one moment. Sorry, apologies for the sneezes there. So we're looking at a structural. Apologies one more time. So we're looking at a structural target, and interestingly, FPCT is an analog of cocaine, so we need to be quite in other stimulant medications. So we need to be quite careful about what patients are on when they come in for this scan. So there'll be a medication checklist. The advantages of this particular tracer is that it has fast kinetics, and we get this great high signal to noise ratio, which gives us really nice clear images. And you'll see what I mean in a moment. But let's start with the anatomy. We're really looking at this part of the brain, so the putamen, and then the caudate coming around. And keep note of the amygdaloid body as well, because you can sometimes just see that on the studies. But the putamen and the preservation of the ventral and dorsal putamen is an important area for us to assess. So let's play this little video of how I set this up. And this isn't MIM. I couldn't take a screen cap. This is just using another viewer called Radiant, but we can still work with it. Just mimicking what I do. So I adjust my levels. You can really see that we want to kind of play up and down until we can see the internal detail of the caudate and putamen. Great, and then I'll line it up along it. And I like to use MIPS as well. I find MIPS are super useful, particularly if you line them up along the body of the putamen, And you get a real sense of what we look like. So there we are. So I'm lining it up along like that. And then I'm going to put on the MIP tool and then kind of scroll in a moment, but already I'm scrolling back and forward, looking at the caudate, comparing side to side, considering that asymmetry. And then you'll see on the MIP just how nicely we can capture, when I turn it around, that morphology. And so what you can see there quite beautifully is this MIP here. And you can always see the amygdaloid body, which I just think is so gorgeous. So putamen, caudate wrapping around, coming down all the way here. And that is a normal study. That is what you expect to see. And I like to think it looks like a bunny, but we've got to give bunny much longer ears to account for that. And there we go. There's our anatomy again. And just to overlay it, that's what we're looking at. In comparison, this is an abnormal study, and you can see that the back of the bunny or the dorsal aspect of the putamen has essentially reduced uptake. And here, if I draw it out for you, so this is a nice normal study, whereas here you can also see reduction in the tail of the caudate as well. And I'll be looking at these side by side, particularly on a rainbow. So I use rainbow. My colleagues will use warm metal, that purple scale that we saw before. And we're looking for symmetry. So in a normal study, we're looking for that symmetry. So caudate head is just up here. This is the caudate head, and this is the putamen. But here you'll notice the tails of those putamina are decreased, and it can be asymmetric. You can also see reduction in the caudate as well in the ventral part of the putamen, but we're looking side to side for looking for loss of that normal pattern. And this is consistent with Parkinson's disease. There's a few different ways to remember this as well. I would think about them as commas and full stops. Comma, we're seeing the tail, and full stops, we're not seeing the tail on the comma. So commas and full stops. But when I was over at MCW, I had a new one, which was shrimp and scallops. So if you have the tail of the shrimp, or the scallops being rounder. So however you read it locally, whether it's commas or bunny rabbits and full stops or shrimps and scallops, whatever helps you to remember the morphology. And just to throw in another case here as well, so normal and Parkinson's disease, that case that we saw before, and this one is an atypical Parkinson's disease. We're not only seeing that, we're losing kind of the more ventral aspect of the putamen, but the caudate is down too. There's a bit of preserved uptake here, but we've really lost that beautiful signal. And even that signal to noise ratio is less because the tracer isn't being taken up where it should be. So this is an abnormal study, and not all that we see on these FP-SIT scans is necessarily going to be Parkinson's disease. It can help us with the assessment of a range of neurodegenerative conditions, including MSA, both P and C, progressive supranuclear palsy, even diffuse Lewy body dementia, or corticobasilar degeneration. But essentially, we use these in conjunction with other modalities. Is FP-SIT going to be the first line for a lot of these cases? Probably not. Like they'll often come to us with MRIs and CTs, and we are certainly a problem-solving investigation, and often for patients who have had then maybe presenting younger or with atypical symptoms or refractory to treatment. Okay, so we're going to move on to some brain tumor imaging, and we're going to, no questions? Great. Feel free to keep putting the questions in the chat box as well. So let's move on to brain tumors, and we're going to briefly stop at FDG. FDG has been used in the brain. It was actually brain imaging with FDG PET was probably one of the earlier applications of PET before it got railroaded by oncology and body imaging. So brain tumor imaging with this has been, a stalwart for such a long time. But that said, assessment can be difficult because we know that the brain takes up so much sugar, so that signal to noise ratio can be reduced. So we need to be very careful with our scale adjustments and also correlating it with the diagnostic imaging, whether that be MRI, ideally, or a CT. Note as well that certain different brain tumors can have variable metabolism. Often high-grade disease will have higher uptake, glioblastomas, grade 3 lesions. Even some metastases will be hotter, but small lesions are difficult to detect. We don't have that spatial resolution. We don't have that signal-to-noise ratio. We don't have the contrast resolution that MRI does. And so in no way I'm advocating that we should be taking over for those modalities. But we're useful in problem solving. So if you see a lesion, we can kind of help with the decision-making and leading down one path or another. And then also keep in mind that some benign neoplasms and inflammation and infection will also be FDG avid as well. So encephalitis, we don't help a lot. Encephalitis versus tumor, both can be hot, so that's a bit of a tricky one. So here again, this is actually the kind of the case that we were looking at earlier. This patient came in with for a dementia assessment, and I just like it because it shows how when we turn down the brain, we really need to look through, because you need to be looking through the background metabolism for increased uptake. And if you look down towards the base of the brain here in the pituitary fossa, we'll come back up again, you'll notice that there is something popping up right there in the middle that is bright red above background. And this was a case of a incidentally detected pituitary macroadenoma in this patient. So they can also be really hot. Occasionally you'll also see them on body imaging too, which is why you've always got to look through the brain. This is a nice case I took from Radiopedia, which is a good example of where FDG can be used for problem solving. This was a patient with an optic chiasm glioblastoma. And then if you look through here, there's corresponding abnormal uptake through that. So that was useful in problem solving a difficult region. And you can see that that could be used for surgical or radiotherapy planning, depending on what was happening. And another useful case, and this leads right on to our next section on FET. And this was a grade 3 oligodendroglioma, which didn't have a lot of enhancement at the beginning. And so a debulking surgery was performed. You can see it there with flare hyperintensity, cortical expansion, not a lot of enhancement. But after the patient underwent their debulking surgery, one of their progress MRIs demonstrated an enhancing nodule. Unfortunately, I don't have that image, but this is what on the MRI. But let's have a quick look at what the PET showed. So just scrolling through, you can see that as we go up, and we're going to ignore the bright spot for a moment. I'm just going to show you the surgical cavity as this relative area of low signal, and then low tracer uptake. So this is just all what we expect to see post-surgically and normal brain. But here above normal background is this bright spot. So this was concerning for tumor recurrence. The patient had not had radiotherapy, which is an important diagnostic consideration, as we'll see in a moment. And unfortunately, this patient did progress and they recurred. The higher grade component of the lesion was seen as the FDG avid abnormality. Okay, just looking at our questions, a great one from Nitesh. It's not one that I don't think I can answer well now, and it's a little bit kind of outside of the scope, but I'm going to take it down. If you'd like to so for the question about amyloid PET, BAPL scores, and also FPC in terms of PD or PD plus syndromes, if you'd like to shoot me an email, I'll put my email at the end as well, and I'll be able to answer that one offline for you with a little bit more nuance, I think. So thank you. That's a really great question. Okay, so excellent. So Katie has anticipated the next part of my talk. So is there a differentiation between radiation necrosis and tumor necrosis using FDG or other alternative radiant tracers? That is a great question. And one of the hardest things that we can do is trying to determine whether it's radiation necrosis or true progression. Really tough. Yes, no, I got what you were talking about. Perfect. Thank you, Katie. Yes, so is it recurrence or is it radiation necrosis? Because both can be hot. FDG, it's a very sensitive but not a very specific tracer. So inflammation can certainly be hot on PET of the brain as it can elsewhere in the body. And so what do we do? Because on MRI, radiation necrosis and tumor progression can look the same. So one of the tools that we have in our arsenal at Royal North Shore is FET. And that's another agent called fluorylethyltyrosine. It's an amino acid PET, and it is taken up by glial tumors. And we'll often use it in conjunction with FDG as well, and also some time activity curves to try and distinguish between radiation necrosis and recurrence. Are we perfect? No, but no imaging modality is. So often our radiation oncologists and our medical oncologists and our neurosurgeons will sit down with us and we'll try to, work it and almost like, problem solve based on which one is more likely as well. So that's a fantastic question because that's one of the challenges that we're working on. So FET, it's a molecular imaging agent. And it's a supplement to MRI. It does not replace MRI, so we use it all together. And the few reasons that we use this is for monitoring patients' clinical features, imaging features will all come into it, and FET and FDG PET are often an adjunct. So here's a nice example of just a straightforward one. So this is a patient who had multifocal glioblastoma on both sides of the brain. So a left temporal lesion and a right parietal lesion here and here. So these enhancing lesions. And then they had a pre-treatment FET scan just for delineation. And you'll notice that when I play the video, it's coming up. We'll have that spot here just in, have I indicated it? Yes, there in the parietal region corresponding to that rim enhancing lesion, and then intense FET uptake medially within that temporal lobe corresponding to the more dominant lesion. So we already know that we've got multifocal disease, and this patient went on to have therapy, radiation to both of those regions. And unfortunately recurred. So in the parietal region, which was distant with these mass-like areas of enhancement, there was a question, could this be radiation? But this was very FET avid, and with the distribution and the correlation with the radiotherapy fields being outside of it, the areas of boosting, that this was thought to be recurrence, and yes, it was. So here's actually, this is the baseline at diagnosis, and here's the recurrence as well, showing that the FET distribution helped them to map the disease and come down with more diagnostic certainty. And moving on to dynamic imaging, which is one thing that we really do if the clinical question is recurrence versus pseudoprogression or radiation necrosis. And we're looking at something called a time activity curve, where the tracer washes in and washes out over time. So we're looking at blood flow, similar to what we do for dynamic imaging in breast cancers, even in arterial enhancement and hepatocellular carcinomas. So that malignant kind of pattern of wash in, wash out, as opposed to inflammation, which should theoretically just accumulate tracer over time. And so we use this information, we take measurements over 40 minutes of continuous imaging and then create a time activity curve, which can have 3 different morphologies. Yes, Avastin, if it does decrease the blood supply, yes, it will impact things. We don't tend to image patients on Avastin. Prednisone and Dex, I'm not too sure, but most patients will come to us with prednisone and Dex, so I don't think so, but fact check me on that one. Thanks again, Katie, for a great question. So let's look at those 3 time activity curves. So here is a type 1 increasing curve, and this is typically our inflammation curve. So it's continuously upgoing like this. And then a plateau curve, which is going up and then it's staying flat. And now we're starting to get worried. Plateau curves can be seen in high-grade glial tumors. So this is starting to get concerning. And then a type 3 or decreasing curve, which is very concerning for high-grade tumor. So over time, we're getting a peak and then starting to decrease off. And so this is the pattern that the textbook says is most consistent with tumor recurrence, whereas the type 1 curve, which is this one, is more consistent with radiation necrosis on FET. There is some overlap because FET can be taken up in areas of inflammation, but it's just, as we said, it's just another tool that we have in our problem-solving arsenal, which can help us here. And a bit of a demonstration case. Here's a patient with a tumor cavity. They've already had it resected. They've had local radiotherapy. They've had this patchy enhancement posteriorly to this. The question was whether this is tumor recurrence or is this radiation necrosis or pseudoprogression. And yes, it was FET avid. But can we call it based on this FET alone? Because both can demonstrate uptake. No, we can't. So let's have a look at our curves. And the curve demonstrates that morphology, that upgoing, up, and then down curve, or like, I know with an eye faith it looks a bit plateauy, but I think there was an up and we considered that was going down with our peak kind of around the 15 to 20 minute mark and then slowly decreasing. So this study was reported as concerning for high-grade malignancy, and that diagnosis was confirmed on progress imaging. Okay, so stopping briefly at gallium-68 dotatate, which a lot of you might kind of come across as a neuroendocrine tumor marker. So this was a patient with metastatic small bowel neuroendocrine tumor with a dotatate scan. This spot in the brain is the pituitary, so we just need to keep that in mind looking at brain imaging. And also this was a nice example I had of a pancreatic insulinoma. Look at that. Just gorgeous. But we can use dotatate in the brain because meningiomas have somatostatin receptor expression, which means that they are avid on dotatate scans. And sometimes we detect these incidentally. But where does PET, if someone does have a meningioma, where does PET dotatate add value? Where does gallium-68 dotatate add value? Because we know meningiomas are well characterized on CT and MRI especially. So you don't want to be doing a dotatate scan for everyone with a meningioma. But if you are looking to treat or you're looking to characterize atypical lesions like on plaque meningiomas or where there's bone involvement or osseous meningiomas, That pituitary is normal, but this is all on plaque and intraosseous meningioma through the sphenoid, or this really nice case here of this one at the orbital apex where there was this thickening and then there was focal dotatate uptake. So this was a little tiny meningioma at the optic canal or the optic nerve. There we go. Nice. And so we can use it in some patients, some select patients, for predictions of growth and outcome, for therapy planning, for radiotherapy or surgical resection, and also for theranostics. We'll come back to theranostics in a moment, but I will just show you some nice radiation contours that the dotates have used just from a nice article I found. So contouring the lesion based on the dotatate uptake and then being able to deliver more targeted radiotherapy to these atypical meningiomas. And just a little quick couple of animations about lutetium therapy, which you would have seen with prostate cancer, neuroendocrine tumor elsewhere, but there is an application in meningiomas. So with diagnostic imaging, Gallium-68 is our positron emitter with dotatate, which is our pharmaceutical, but you can swap it out for lutetium-177, which is a beta emitter. So particle radiation can be used for targeted radiotherapy. And how does it work? We've got our receptors on these cells. In this case, it's going to be a somatostatin receptor, and then we send in our somatostatin receptor agonist. Sorry, no bad. I just press play. There we go. So then the radiopharmaceutical will come in, and for diagnosis, it will come in and then it will send off our gamma photons for us to be able to image it. But in treatment, it will be taken into the cells as well. So this is our diagnostic. But if we've got a particle radiation and it's in there, then it's going to be throwing out these electrons. What type of damage is that going to do to the cells? Well, if we get it in the cell, then it can hit the DNA. And so the electron, it's a big particle, it causes damage. And then it can cause double-stranded breaks within the DNA, and this can be fatal to the cell and then cause apoptosis. So same theory of radiotherapy elsewhere. So apoptosis, getting the beta emitter into the cells exactly where it needs to be and causing cell death. And here's a nice case. So on the top is the dotatate. This is a patient with multifocal meningioma who'd had multiple craniotomies, but just kept coming back. This was an atypical histopathology. And then on the bottom is lutetium dotatate therapy. So really good targeted therapy. Just running through to the end, a brief stop on F-MISO. I don't have any diagnostic cases, but just to know that this is in the research realm. It's an imaging of hypoxia. So we're looking for changes in oxidation pathways and cell hypoxia. So this is firmly in research, but detection of hypoxic tumor cells can help with our detection of necrosis and upstaging and considering about the patients and how they will interact to therapy and respond. And this was complementary to MRI as well. And that's just a nice example of an F-MISO scan. So in the last 3 minutes, just a bit of a show and tell about F-choline, just because I've got some such beautiful cases of parathyroid adenomas, which so choline transporters, it's upregulated in pituitary adenomas and it's incorporated into the cell membranes. And so it gives us a really nice signal to noise and really clear imaging. Traditionally, we've used cestamebe and 4D CT and ultrasound for assessment of parathyroid adenomas. But sometimes, because parathyroid adenomas can be multiple, they can recur, they can be in strange places because of variant anatomy. We're looking for better agents all the time. And this is one of the choline studies. And you can see this patient actually had multiple surgeries already, and they were still having refractory hypercalcemia. So if I spin the patient, you'll notice in the chest there are 3 dots, and they should not be there. The muscle uptake, the liver, bowel, that's all fine. Salivary glands, that's fine. But those dots should not be there. And so here, superiorly, we've got one kind of typically located parathyroid adenoma in the tracheoesophageal groove, another spot posterior to a surgical clip after one had already been resected, and then moving a little bit further down, inferior to the aortic arch, is a very large parathyroid adenoma with intense tracer accumulation, which definitely would have been caught on ultrasound. And you'll say, well, Sally, surely this would have been caught on a cestamebe scan. Well, actually, no, it wasn't. So here's the cestamebe on screen left and the choline on screen right. And there's, oh my gosh, you can just see maybe a bit of uptake through there on the MIBI study, but so much better on choline. And just so you believe me that there's a few other examples and I just haven't given you one. Here's one more. There's one coming through here. another one just in the neck, in the tracheoesophageal groove here. And a last one more anteriorly. You can see the variable uptake based on the scanning times, but really nice study. And it is, in a lot of the analyses, is showing really good positive predictive value and also good sensitivity above 90% compared to 4D CT and sestamibi used in isolation. So watch this space and some nice cases to finish up. Great, so it's 9:54. Well, where I am, it's 9:54. Thank you for everyone else you are joining. A few references and a few thanks. I'd like to thank the team at Medality who have invited me along today. It's been a real pleasure. To Associate Professor Jess Shembry, Dr. Sophie Tu, and Dr. Ash Raghavan, who have helped me with some of the content and the cases. My workplace, University of Sydney, Royal North Shore Hospital, and the Australian Total Body PET Facility on behalf of the National Imaging Facility, and also Medical College Wisconsin, and Dr. Mohit Agarwal for the inspiration and some great feedback on curating these cases. So I'd like to open the floor. Is there any questions or anything I can comment? And I know that there was that question about the FPD Plus. I'd love to be able to chat more about that. So please email me. Who was it? So Nitesh Naik, if you'd like to send me an email, that would be fantastic. And I'll also bring in my the local experts as well, who'll be able to give you a really great explanation. But are there any other questions, comments, feedback that I can help with this today at the end of the talk?
Yeah, thank you so much, Dr. Ayesa, for sharing your lecture with us today. And yeah, it looks like, oh, we just had one question pop into the Q&A. Oh,
Great.
excellent talk, says thank you. Very nice.
Thank you very much.
We can wait a few more seconds to see if any questions pop in, but you were answering so many during your lecture. It was great, and it was extremely helpful to the learners.
Oh, wonderful. Well, I hope that you all found it useful. As I said, there's my emails and my content. So if you've got any questions, comments, feedback, things I could do better, please don't hesitate. And I'm looking forward to kind of, meeting a few of you in the real world. So thank you.
Awesome. Thank you so much again, Dr. Ayesa. And thank you to everyone for participating in our noon conference today and asking such great questions. You can access the recording of today's conference and all our previous noon conferences by creating a free account. We'll also be emailing out the link to the replay later today. Be sure to join us next week on Wednesday, December 18th at 12 p.m. Eastern, where Dr. Asim Chowdhury will deliver a lecture entitled Pediatric Brain Tumors, Latest Updates on the WHO Classification Revision. You can register for it at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again and have a great day.